Well, as you can see, I lost my coat somewhere. That was hard work, so we'll try to do this at a more relaxed pace. This is probably not the greatest timing. You just heard a discussion of a lot of these things, and unfortunately I didn't understand what our speaker was talking about. It sounded good, but so forgive me if I repeat a little bit. I'll try to avoid it, and I know it's been a long day, so I will skip very lightly on some stuff that we could spend a lot more time with, but I have a feeling that it's probably going to go because you're so tired at this point. This is a delightful case report. It was written up in a twice yearly newsletter that's actually much more than a newsletter. It's probably about 50 pages long of articles about what's happening with medical cannabis in California in particular, but also in the United States. And this case was described there, and I'm a geriatrician, in addition to being infectious disease, internal medicine, other stuff, but I also take care of old people. And I just love this study this case report from Israel. It's a 75-year-old woman with advanced Alzheimer's disease. And she was in a nursing home for care because she could no longer care for her and her family couldn't care for her in Israel. And for several months, she just groaned all the time. And with Alzheimer's patients, one of the things you have to assume when something like this happens is that they're in pain, because Alzheimer's makes pain worse. It increases the pain response. And also they can't describe to you that they're in pain. She really couldn't talk, so she was just, oi, oi, all the time. And she started losing weight, which is how Alzheimer's patients die. I did a study many years ago looking at how people who aren't sick, but these people didn't even have Alzheimer's, but what happened when they started dying naturally. And what always happens is preceded by loss of interest in food, weight loss, and they just kind of fade away. Well, in Alzheimer's, they lose weight in part because the appetite center, the whole brain is dying, it's not doing well, but the appetite center isn't working right. But I'm sure she was in some pain. A guy named Zach Klein, who was a research graduate student at Tel Aviv Porter School of Environmental Studies, was part of a study for nursing home patients to see how they would respond to the only cannabis you can get in Israel. So ironically, every place else it's some kind of terrible THC pill. In Israel, it's weed. It's not very good. It's pretty weak weed, but it's weed. And that's the only thing you can have there. So you have to vaporize it or smoke it. You have to do something with the herb itself. And it wasn't safe for her to smoke, and she had no coordination. She couldn't smoke. So he would smoke the cannabis cigarette right up next to her mouth and go and blow the smoke in her mouth, and then wait for a while, and then blow a little more in. And she stopped groaning. She smiled. She laughed. Nobody had ever seen her laugh. So they kept doing this. The first thing they did, because the poor research student was getting stoned all the time, they got a smoking machine. So the machine didn't care how often it smoked a joint. So the machine would make smoke, and she had learned how to inhale it, and she started gaining weight. And then they got a vaporizer so they didn't have to deal with the smoking machine. They started stopping medicines. They stopped her terrible clonazepam, really potent, atypical antipsychotic. They stopped memantine, which is one of the Alzheimer's drugs that's pretty useless anyway, and Seroquel, which is a drug that in the US you get seriously dinged if your Alzheimer's patients are on Seroquel. It's a real no-no. They were able to stop them sequentially, and she did, last time, she had been observed for this case report, had been 2 years, and she was doing just fine. Happy, smiling, interactive, comfortable. This is her weight chart. So you can see what happened to what was happening with her weight. She started up there at about 71.5 kilos, and was just going all the way to death. I mean, that chart leads to death. They started the smoking cannabis, and she got a little bit better, and then something kind of happened. Maybe she had pneumonia or got sick there a little bit, and then went back, and the weight just kept on going up. So, case study, case of one, ain't data, not even in a journal. I mean, it was in a serious newsletter, but I communicated with the guy. I said, I want to use your case. Unfortunately, I couldn't get a copy of the picture, which was just wonderful, of this old Jewish lady in the nursing home, with right after having smoked a toke and smiling. So remember the Greek word pleiotropic. Okay, we're going to talk about pleiotropic again with neurodegenerative disorders. Now, as you heard, there are more neurodegenerative disorders, but we're going to focus on two that are quite different, but there's a lot of overlap in how cannabinoids might affect the course and how they affect the symptoms. So the first is Alzheimer's, and the big problem that cannabinoids can address in Alzheimer's, and probably the only problem, but it's a huge one, is like her case, like Mrs. A. It's behavioral. Now, with men, demented men, the most distressing symptom that it develops is sexual disinhibition, and it's just terrible. It's disruptive in the nursing home. It's really hard to manage. But routinely you see anxiety and paranoia in Alzheimer's patients, so-called sundowning. I'm sure everybody's heard about that. When the lights go off, they get disoriented and anxious and start yelling and keep everybody else awake. And then the reason that she was on Seroquel for agitation, to try to shut her up. And there are constitutional symptoms. As I mentioned, pain. They're more sensitive to pain, and they're more likely to have pain. Loss of appetite, as was true in her. And in the case of multiple sclerosis, a separate problem, which is muscle spasms. Now, Alzheimer's, muscle spasms aren't necessarily an issue in Alzheimer's, but they're a big issue in multiple sclerosis. And as you heard, it's one of the evidence-based legitimate reasons for using cannabinoids, and they work. And I think they are safer and work better than other treatments that we use first, like benzodiazepines in patients with Alzheimer's. Bad. Valium, Ativan, you get into all kinds of trouble with Alzheimer's patients. Cannabinoids are much safer for the muscle spasms. Now, the other side of the pleiotropy is, does it affect the disease itself? Now, we were talking about that with cancer. Two big areas. One, symptoms. No question, easy. The other, disease itself, not so easy. Much more difficult data, much more difficult to make up your mind, a lot more clinical judgment that's involved there. Now, the patients I see are different from the patients that other normal doctors see. When patients come to me, it's not a question of should we use cannabinoids. They're already using them. They come to me to get their card, so it's easier for them to get it, and to get my advice. But I don't talk them into using cannabinoids. I'm not going to talk them out of it because they're already doing it and they're going to do it anyway. It doesn't matter what I say. So some of the patients were talking about, stuff that they read on the web about neuroprotection. Well, it turns out there's a really legitimate issue with the possibility of neuroprotection, and it's because of pleiotropy. And this is just astounding. There is nothing else in ways of medications that attacks so many areas that might help provide neuroprotection. Now, with Alzheimer's, as we'll go through, the horse is out of the barn. I don't know if that's a Macedonian expression, but in the West, that means you can't shut the door because it doesn't matter, the horse is already gone. So with Alzheimer's, your brain's, fried, so it doesn't really matter. As we'll see, especially with MS, in earlier disease, there's really some kind of exciting thoughts. Neuroprotection, potential for neuroprotection comes from reduced neuroinflammation. So did you know that Alzheimer's disease is an inflammatory disorder? It is. It's a localized inflammatory disorder. Now, it's more complicated than that, but inflammation is one of the bad things that is killing the neurons. It decreases the death of neurons, and as is true in cancer, it tends to get rid of the dead neurons that are causing inflammation and help or avoid damage to the healthy neurons. It's a powerful antioxidant. It protects from radical oxygen species and inducible nitrogen oxidative species. Throw away all of your other antioxidants. They don't work. Vitamin E, useless, feed it to the cat. The cannabinoids are powerful, powerful antioxidants. So if antioxidants are going to make a difference in neurological disease, this is where to look, the cannabinoids. The mitochondria, as we will see, your brain uses, everybody knows, your brain uses a big chunk of your body's energy. So the brain consumes lots and lots and lots of glucose. So the mitochondria are working hard, but if the mitochondria don't work smart and they get dysfunctional, then it leads into this inflammatory pattern and causes apoptosis through several mechanisms. So it causes neuronal death. So you want the mitochondria to work smart and work better and don't overwork because it leads to excitotoxicity. Now, excitotoxicity is a term I wasn't very familiar with, had vaguely kind of heard about it, but wasn't sure what it meant. And what it means is that the inflammation around the neurons causes the neurons to get overactive. The overactive neuron starts firing across the synapses uncontrollably, and what one of the articles in the literature describes is that they just, kind of wear out. There's a fatigue factor, and the neurons just sort of give it up. So you've got to calm it down, and that's what the cannabinoids do. We've heard this modulatory effect. Instead of getting in a circle like that, the cannabinoids say, okay, slow down, slow down, slow down, slow down. So it slows down the stimulation across the synapse that causes damaging excitotoxicity. There's hope that it actually promotes neurogenesis. Now, we believe forever and ever, I was taught, you may have been taught, that you never get more heart cells, you never get more brain cells. It's not true. It's not like skin cells or, it's not like elsewhere where there's rapid regeneration. But there is the potential for very slow regeneration if it's possible. And cannabinoids promote regeneration. They promote neurogenesis. and they enhance synaptic transmission like Aricept, donepezil, which doesn't work very well. I never use it. But it does have, in addition to all this other stuff, it does have the anticholinesterase inhibitor effect that you use useless Aricept for. Now, there are a couple things that are specific to Alzheimer's. All of these things are not specific to Alzheimer's. They work in neurodegenerative disorders in general. I mean, it's just really exciting, all of the different actions that it has. In Alzheimer's is a disease of beta amyloid, it is thought. Now, a lot of people are pushing back on that right now, but we don't have an alternative theory that makes a lot of sense. Cannabinoids facilitate the removal of beta amyloid from these plaques that are areas that cause the inflammation. The plaques are in the areas of the brain that isn't working, and when you look at the plaques, they're surrounded by glial inflammatory cells, and the cannabinoids calm that area down and facilitate, okay? They help, but it's not like they make the amyloid go away. The house is out, the horse is out of the barn there. But they do cut down the inflammation, and it may be much more relevant, and probably is much more relevant, in diseases like multiple sclerosis. And then the other factor in Alzheimer's disease is neurofibrillary tangles. You've probably heard about the tau protein is part of the skeletal system in the neurons, and the beta amyloid causes the tau proteins to get hyperphosphorylated. Okay, now too much chemistry for this late in the day, but what happens is that when you phosphorylate the tau protein, it starts forming these tangles. So instead of a nice cytoskeleton, nice tubules, microtubules, you get tangles. So, what is this? Am I smoking something here? I mean, can weed really do that? How is that possible? Well, I think if you take away nothing else from today, it's that the endocannabinoid system may very well be the most important signaling system in the body. More important than adrenaline. More important than all of those other signaling systems that we learned about in medical school. The endocannabinoid system really keeps our body working in the way it's intended and keeps things from getting out of control, because it's an on-demand system. So when things get out of control, like a seizure, the excitotoxicity that leads to seizures, it's the endocannabinoids that give you an opportunity to tamp it down and keep things from getting out of control. Now, you've heard about receptors. You've heard about CB1 receptors, CB2 receptors. It probably, if the wonderful plant terpenoids had been discovered first, actually they were, but it was by botanists, and nobody listens to botanists. But if the researchers had really kind of focused on other receptors, the name might be very different. CB1 and CB2 we might not be obsessed with, because the other receptors are really important and the terpenoids are really important as well. So there are all kinds of, you've been spared more or less, all kinds of other receptors, PPAR alpha, PPAR gamma, GPR55, TRP, V1, on and on and on. So that's enough. But there are lots of receptors there. And many diseases, and it's arguable, it may not be true, but it's getting kind of believable that diseases like Alzheimer's and multiple sclerosis get established because the endocannabinoid system fails. It just can't keep up. So it gets tired. It fatigues, just like those overexcited neurons. So here's one. This is actually not a bad diagram. This is about Pleiotropic. Okay, so that's a brain, right? You with me? Yeah, brain? Okay. To the left of the brain is behavioral stuff. That's the easy stuff. You try cannabis, you use it the right way, and the symptoms get better, great. Symptoms don't get better, too bad. You know, it's a therapeutic trial, you tried it. So that's easy. Agitation, aggressiveness, food intake, and maybe some cognitive improvement. It happens in mice. I mean, mice aren't very smart to begin with, but you know, mice that get Alzheimer's, they get a little bit smarter when you give them cannabinoids. Now then there's all of this other stuff, and that's what I'm talking about. That we go around in a circle, and we'll talk a little bit about the data, but improved neurotransmission, improved vascular effects, so improved blood flow, anti-inflammatory effects around the astrocytes and glia. Tau protein, we talked about that, slows down the hyperphosphorylation of tau protein. It helps the mitochondria work better and smarter. It's anti-amyloid and may facilitate removal of beta amyloid. And then there's some other stuff down there in the corner. You probably can't see that anyway. Okay, we've got to know what Alzheimer's is if we're going to put together an argument for the possibility that cannabinoids can have an effect on Alzheimer's disease. There are many factors in Alzheimer's disease. You know, the most prominent one is aging. Duh. I mean, we all knew that. Don't need Dr. McCue to tell you that as you get older, you're more likely to get Alzheimer's. And there's some other things we don't understand very well. Genetics plays a little bit of a role, but the whole thing of, you know, women being more likely to get Alzheimer's and it goes in families is way oversold. Genetics plays a relatively minor role, except in dementia precox, the premature Alzheimer's that occurs in 50-year-olds, that sort of thing, or in even younger. That's really genetic. But the standard garden variety of Alzheimer's, the genetics are really not nearly as important. So that leaves us with, we really don't have much of an idea, but what happens is there's this protein precursor and secrases get activated and they cut this protein precursor at number 42, magic number there. When they cut it at 42, what's left is called beta amyloid 42. Not very imaginative name, but beta amyloid 42 is alpha amyloid and beta amyloid clip. Beta amyloid 42 is toxic and drives the immune system bonkers. So the immune system just goes nuts and the endocannabinoid system can't keep up with it. The inflammation that draws all of the microglia in, you know, and causes the cytokines and all of the inflammatory reaction starts feeding on itself. So the poor endocannabinoid system needs some help to try to slow it down if the disease process, and it's a big if the disease process can be interrupted. And the inflammation is what causes the neurons to die. And you know, in MS we'll talk about demyelination. There's a lot less emphasis on demyelination now rather than more emphasis being put on dead neurons. The neurons just give it up. Now, in animal models with Alzheimer's disease, they're not super good. You know, it's kind of hard to recreate a disease like Alzheimer's in rats and mice. You know, Alzheimer's develops over decades, and you know, mice and rats don't last that long. And you really can't completely replicate this clinical thing called Alzheimer's. But the studies that have been done show that the endocannabinoid system is really right in the middle of all this. And if you augment the endocannabinoid system in animal models, in mice and rats, then you can help the endocannabinoid system reduce inflammation and stop hyperphosphorylation of tau that turns it into p-tau that causes neurofibrillary tangles. And it works with plants. It's magical, you know, as Dr. Russo, by the way, Dr. Russo is one of the top 5 or 6 researchers in cannabinoids in the world. You know, he really is a pivotal person in the way our understanding of cannabinoids has evolved. So you're very lucky. I'm very lucky. The animal models are really, you know, kind of stupid. You cause genetic predisposition to beta amyloid. You know, that's not what happens in people. That's a genetic mess up in mice. You know, and that how that relates to Alzheimer's is, you know, not at all clear. Or even stupider, you get some beta amyloid and you inject it intraperitoneally. You inject it in the mouse belly. You know, and that certainly is not a very good model for Alzheimer's. So we can't put much emphasis on the animal models. But it does replicate lots of those things that I showed in the brain slide there. I'll just cut to the chase here. Pleiotropy in the animal models, all of those things, 5 or 6 things that I pointed out, you can replicate in an animal model, accepting that the animal models are unreliable in studying Alzheimer's. So we don't have much in the way of human studies. Okay, we got the 2 areas. One is symptoms, and the other is disease protection or reversal, protection from disease. There was an autopsy study, and they look for cannabinoid activity. They look for endocannabinoid activity, and they show that in autopsy studies of Alzheimer's, the endocannabinoid system is what they call overrepresented, that there's a density of receptors there, meaning that it's hungry, it wants more of the cannabinoids. And it correlates very well with the symptoms. So there is some brain slice evidence for involvement of the endocannabinoid system. Now, you know, can't take that very far. In 1997, 15 patients with probable Alzheimer's, you know, and that's part of the trouble with this literature in general. Probable Alzheimer's and weight loss got low doses of THC, dronabinol, twice a day or placebo for 6 weeks, and then they were crossed over to the other treatment. Well, actually it was positive, except one of the things that recurs in the cannabinoid research is the researchers don't know anything about cannabinoids. They don't know anything about doses, they've never smoked a joint, they haven't talked to people who smoke joints, and they come up with all these cockamamie doses, and they come up with short treatments, and they're just poorly designed studies because they don't know what they're doing. They're just kind of poking around trying to figure out something. So the dronabinol THC group gained more weight. They gained 7 pounds over 4.6 pounds, but the secondary part of the study was their behavior, and their behavior disturbances got better. The problem with the study, the reason it's said to be negative and the Cochrane database says, you know, can't use it, is they didn't have a washout period. So really stupid. So you've got active drug and then switch to placebo and nothing in between. Well, you're supposed to stop the active drug, let it wash out, and then start the other way. So placebo, active drug, washout, active drug, placebo. That's how you're supposed to do it. They didn't do it. And so they said it was a negative study because after they stopped the dronabinol, the patients still stayed better while they were on the placebos. Well, we know that happens with cannabis. If you give somebody cannabis for a problem like pain or, you know, almost any of the indications, and then you stop it, the symptoms don't come back right away. It takes a while, and then the symptoms slowly return. So what was happening here is something that we see that you know happens all the time, that you can use cannabinoids intermittently. You can take them for 3 or 4 days, stop them for 3 or 4 days, take them for 3 or 4 days, because the effects tend to lap over into the washout period. So there are 3 randomized controlled studies of 2.5 milligrams of dronabinol at bedtime. It's a low dose, as you heard. That's the lowest dose at which you might see some psychoactivity. This is in Alzheimer's patients. It was open label, which is the kiss of death for reviewing a study. If it's open label, then there's the opportunity, enormous opportunity for bias. 24 patients in another study got THC, placebo, or 3 milligrams of melatonin. I don't know if anybody has used melatonin here, but talk about a useless drug. Maybe if you're an airline pilot, I don't know. The nocturnal activity and the NPI, you'll see neuropsychiatric inventory pop up a few times, got significantly better in the dronabinol group from baseline. So they saw a significant difference. And then there was 2 patients with nighttime agitation that they did a follow-up study on, and it only had 2 patients because they couldn't find anybody else to enroll, so they had to terminate the study. But in general, these studies in humans were encouraging. They just weren't very good. Then there are a couple of case reports of older men with sexual disinhibition that drives nursing home nurses and other families and patients crazy, and they got better. The recurring story here is they try all these awful drugs, they don't work, and you start them on cannabinoids and you can stop all the awful drugs that don't work. Oh, and then there was a study that Harvard should be embarrassed about at the McLean Hospital when some psychiatrists looked through charts and discovered that everybody who got cannabinoids in addition to their usual medications got better. Well, hopefully they were at McLean, the best psychiatric hospital in the world. They were getting better anyway because they were giving them the right medication, so bad study. There's another randomized controlled study of 1.5 milligrams of THC 3 times a day. Okay, you've already learned not enough. And guess what? It was negative. It was a follow-up study to 0.75 3 times a day. Now, didn't these guys learn anything? I mean, what I learned is that if you don't use enough of a drug, it doesn't work. I think we know that, right? We'll agree on that one. And they said, it's kind of too bad that we didn't use the right dose, but when you've got studies like this and the Cochrane database grabs them, it's a negative study, and so it kind of points against there. Then there's another open label study, and open label studies just have so much opportunity for bias, but it was positive that they had less delusions, agitation, irritability, better sleep, less apathy, and the caregivers didn't get tired, and that's a real problem in Alzheimer's disease. You just wear out the caregivers. There's nothing on neuroprotection. No studies at all that show that cannabinoids might affect the course of Alzheimer's. But we're going to talk about multiple sclerosis, and there's a big lesson from multiple sclerosis that probably pertains that you should really seriously think about with your Alzheimer's patients. It's something that seems to be just kind of skimmed over, but it's solid data in a good study that should get us thinking. So I'll hold that out there. Then you have to put up with, there's our brain again, you have to put up with MS so we can come up with that study. Conclusions, cannabinoids have wide range of action, behavioral, and then maybe disease modification, no good data. Animal studies, probably forget it. They tend to be positive, but if they're negative, they tend not to get published. So that really is not very reliable. Human studies are all bad, but there is a message there that it works for neurobehavioral symptoms. Okay, multiple sclerosis, I don't have to talk you into this, is an inflammatory disorder. Okay, now we learned today that these are powerful anti-inflammatory agents, so there may be a role here. Multiple sclerosis has been around for a long time, but it wasn't until 1868 that the famous Charcot of Charcot-Marie Tooth and all kinds of other neurology, classic neurology descriptions described what turned out to be multiple sclerosis. It wasn't until 1965 that there were diagnostic criteria so we could agree on what multiple sclerosis was. And then it wasn't until 2010 that they were refined and MRI was added. And MRI is now absolutely key to the understanding and evaluation of multiple sclerosis. It's still defined the way we learned as med students. Neurological signs and symptoms separated by time and place, meaning 2 episodes with involving 2 different parts of the brain or spinal cord. But now that MRI is along, neurologists are very comfortable making a presumptive diagnosis just with the MRI or using the MRI in the first episode and saying, this is what it is. Genetics clearly has a role in causing Alzheimer's disease, multiple sclerosis, but there are other risk factors there. It's still not very clear, but in general, it's thought that it's an autoimmune disorder. When you hear autoimmune disorder, then the cannabis researchers get interested because maybe there's something that's going to happen. The autoimmune basis is that the inflammation causes breakdown of the blood-brain barrier, so activated T lymphocytes and other scavenger cells get into the CNS where they don't belong, and plus the microglial cells are all activated, and the result is demyelination and nerve cell death. Now, this is important if you're thinking about cannabinoids and multiple sclerosis. There are 2 basic clinical courses of multiple sclerosis. There's the relapsing remitting, which is by far the most common. And in between an episode, you either have full or partial recovery until the next episode occurs. Now, that kind of MS is highly treatable with corticosteroids with an acute episode and DMT, biologics with all those names you can't pronounce, like teriflunomide, and there are some other ones there that I didn't put in because I can't pronounce them. They change the course of the illness. They've been revolutionary. Now, can maybe cannabinoids help in there? Because the biologics work by dampening down the inflammatory response. But nobody likes them. They're really expensive. They're very unpleasant to use. They're always, pretty much always injectable, although there is now an oral medication, but it's not one of the biologics. On the other hand, with progressive disease, either primary progression, which is the kiss of death, or secondary progression, which occurs in half of the relapsing remitting cases. The secondary progression can't be treated. Nothing seems to alter the course. So, that's one of those things with cancer. Why not? Hey, let's give cannabinoids a trial. Let's see what happens. And that's what the patients did. So how did doctors get the idea that cannabinoids might do something in MS? The patients told them. Okay, these were AIDS patients in San Francisco who had friends with MS and said, hey, try my weed, see what happens. And the MS patient said, wow, this disabling painful muscle spasms that, it's just, that happens very, very commonly in MS, almost universally. It got better with cannabinoids. And then suddenly the doctors started paying attention. The first study was in 1981, which is just the beginning of the AIDS epidemic, the crisis. And this is the study in which the patients said to the doctors, hey, doctors, pay attention, something's going on here. So there was a very simple trial, 9 patients, and there was a dose response, which is a very good sign of an active drug. If a little bit more works better than the first little bit, then there's a good chance that you've got an active drug. There are some animal models, not very good. It's experimental allergic encephalomyelitis, EAE, and it's kind of, sort of related to MS, but really not very dependable, but some evidence there that the endocannabinoid system is involved, and kind of tinkering with the system might make a difference. Then there are some clinical studies on symptoms. Central neuropathic pain, like neuropathies, pain from muscle spasms. There are good, solid, evidence-based indications for cannabinoids. No question, even Cochrane will agree on that one. There's some evidence that patients say it helps their bladder symptoms. The evidence is not very good, but the patients will tell you that it helps their bladder symptoms. Now, part of that is that cannabinoids cause dry mouth. Your patients will tell you that. So it's anticholinergic. The anticholinergic effects help continence. So it may not really have much to do with what cannabinoids are doing, except the anticholinergic side effects, or the anticholinergic effects. There's a massive amount of data with Sativex, just huge amount of data that is kind of confusing. It's not clear that CBD is adding anything, because the studies overall show that it may just be THC that's really doing it. But the trouble with Sativex studies is the dose of CBD is too low. The doses you've heard today are much higher than the kind of doses that go along with Sativex, so we're not sure. The other big problem, and you'll hear about it, is the Ashford scale. You can go home and forget that one, but the Ashford scale is how you measure spasticity by doctor assessment in multiple sclerosis, and it's a bad instrument. It's the standard instrument that all the studies used until somebody figured out, it's not any good. So we're doing all these studies using the Ashford scale, and no wonder it's not working. There's something wrong with the measurement itself, so it's had to be modified, and suddenly the studies started getting positive because they improved the measurement. So here's an example, smoked cannabis. Most of the studies are with drugs, and they're bad, as you've heard. They're really harsh. The THC, dronabinol, it's late, nabilone. Those kind of studies are they're synthetic, and they're kind of harsh with patients. This is actually what patients did. They smoked. 2/3 of them had some kind of mobility aid, a cane or a wheelchair, because of the spasms. 80% already used cannabis. 20% had never used cannabis. So they had 30 patients who completed the study, and the bad part of the study, it's the NIDA cannabis. This guy who's got the lock on government cannabis in the US, in Alabama, grows bad cannabis, stores it badly, unreliable, real garbage. And it's the only kind you can get legally in the US. Now that's changing. It's fortunately changing in some states where you can actually get decent cannabis to do studies of inhaled cannabis. And the results, look at that, lots of zeros there. P less than 0.0001 with spasticity scale. And this is the better Ashford scale. And the analog measurement of pain that I screwed up before, where I said, oh, they got 2 points. The analog scale changed 5.28. That's huge. And again, 0.008. So not a terribly good study, small, no blinding. The patients were cannabis users. They knew when they were getting placebo. That's placebo. They knew when they were getting the drug. So this very serious opportunity for bias that basically invalidates the study. And the cannabis was garbage. So this is what the data looks like, but still, for garbage, it's kind of interesting. We won't spend a lot of time on this graph over here, but you can see the open circles are cannabis before and after treatment. Big swings in the Ashford scale, placebo, no real change. Over here, it's even more dramatic. That is placebo on the left and cannabis on the right. Huge difference in the spasticity scale. Then there's the CAM study, and it's kind of tragic that the CAM study used this terrible tool, the Ashford scale, that basically invalidated the study, and you can't do blinding. It's a serious problem in all the cannabinoid studies, and you have to pay attention to it. You can't blind people to cannabinoids because they know when they're getting THC. And this is the results, no difference. The solid line is placebo, and actually, placebo worked pretty well. So if you took away anything, is give your MS patients placebo. But it's the Ashford scale. It's bad. So you can't read this, but I put it up here because I found it very interesting. You hear this over and over. This is the doctors do the Ashford evaluation, and then somebody actually talks to the patients, and this is what the patients said. They're in red there. Spasticity. Patient said it helped, highly statistically significant. Pain, it helped, statistically significant. Sleep, it helped. Spasms, it helped. Then there's some other things they said it didn't make a difference in. I know in these studies we blind, we do placebos because we don't trust what our patients say because of the placebo effect, but sometimes it really helps to listen to what your patients are telling you because, it's their body, and sometimes with a disease like MS, they know what they're talking about. And then they did the 12 months, so it was negative, as I showed you, negative. 12 months later, they repeated the evaluation, and it was positive, highly statistically significant. And maybe two messages. One, over time, there was an effect, and that isn't nonsense. There is a reason to believe that. And it just may be that it took longer to have the statistically significant part come out of it. Now, this is why I've made everybody sit through this. This is the Cupid studies. This is a really good study that unfortunately will not be replicated, and it is said, if you look in the literature, it was negative. Cannabinoids didn't do anything. 498 patients, they had the bad kind of MS. So they had progressive MS, untreatable MS, and they were either randomized to THC, the synthetic, or placebo. And the primary outcome was disability, the EDDS. It's some secondary measures as well. There was a huge problem with study design. Most of these patients had advanced disease. The horse was out of the barn. This is an attempt to shut the barn door, and the horses are already in the neighbor's field. if you've got patients who are end stage in disease, you're not going to reverse it. They're end stage. The brain that, that you might be able to improve is already dead. You can't improve dead. But they did subgroup analysis, and they looked at 149 of these patients, a third of them. Now, 149 is a lot of patients. They looked at whether it made a difference if they weren't end stage, if they were early. And it did. Statistically significant. And this is what it looks like. This is the overall study. We'll all agree, no difference. Dronabinol, THC, placebo, no difference. But then when you separate out the 149 patients, this is one of those scatter meta-analysis kind of Cochrane sort of things. What you should pay attention to is that box over there. The patients who had a low disability to begin with, highly statistically significant response to THC. In the other cases, in the advanced disease, no effect. Now, this is risky. I mean, because the study is said to be negative. It's not negative. It just had a terrible design flaw. It's highly provocative, and there's possibly a message in there for Alzheimer's disease, and some smart people are picking up on this and saying, we're starting these meds when patients have dead brains. Like the poor lady in the nursing home, they blow smoke in her mouth. That's not going to do anything for her Alzheimer's disease, but it makes her calmer and happier. But suppose they had started it 15 years earlier. Might there have been a difference? Maybe. So Pleiotropic might have made a difference. Okay, to summarize, you heard this from your neurologist a little earlier. There are lots of symptoms there, absolutely legitimately treated with cannabinoids in MS patients, pain, spasms, insomnia, and there may be an effect on tiredness and bladder symptoms, but not good data there. And you can hope for neuroprotection. That study, the CUPID study, is very encouraging. The dose of THC used it's getting boring here, but remember that number, 5 milligrams 3 times a day, makes it a lot easier. And that really, you have to build up to it. If you started at that, you're going to get a lot of failures because patients will have reactions. But if you start it lower and build up, the usual dose that works is 5 milligrams 3 times a day. And just a little clue, a little trick of the trade that patients will tell you about, that one of the tricks is you dose it up until you get psychoactivity, and then you cut the dose in half. The half dose is most likely to be acting on the disease, and you don't have the complicating factor of the psychoactivity, which really puts a lot of patients off. And in these studies, there's no evidence that CBD made a difference. That may, that doses of CBD are way off. They're just way too small in these studies. But in the studies, THC plus CBD was no better than THC. I think we covered that pretty well. So I'll get California on you here. Now this, I don't know, is very useful for you, but this is what I deal with my patients, because they all grow. And they say, oh, I ask them, what do you grow? And they say, I don't know, I think it's Pineapple Express. How do you know it's Pineapple Express? Well, my neighbor gave it to me 5 years ago, and I've been growing it ever since then. And I said, how did he know it was Pineapple Express? Well, somebody told him it was. And over 5 years, the plants probably changed. Plants tend to evolve, tend to change. So cannabis plants are not necessarily stable unless you put some attention into it. So if you're going to use phytocannabis, then what's usually advised is the plants that have myrcene that patients call indicas, that are calming. Purple urkel, anything that has purple, that's good. Granddaddy Purple, Bubba Kush is one of the classics that is potentially helpful for the calming effect and can be used in Alzheimer's disease. And if it's used early with MCI, mild cognitive impairment, like I have, where I forget how to use the pointer, that's the time to start using cannabinoids if there is some hope for neuroprotection. And then what I tell the patients to grow is cannatonic, 2-to-1 CBD to THC or Harlequin, or a really cool strain, AC/DC. Now you have to, these names are made up by people who are stoned, so you have to be patient. I mean, they're clever, but AC/DC has 20-to-1 CBD, a high CBD strain. And I think if CBD is going to make a difference in it, in this disease, I go back to what I said before, you need THC. And THC is what most of the studies have been done with. But if you're going to use CBD, you have to use higher doses. And if you're going to use phytocannabis, plant cannabis, AC/DC is really where to go. In the Cupid trial, the encouraging Cupid trial, the dose was good old standard 5 milligrams 3 times a day of THC. Boring. And I think, the problem in these diseases with side effects is that there's just not enough CBD. And no real difference with MS. I won't summarize. You've already heard too much anyway. This is the slide that when I screwed up in the last talk because I couldn't get the pointer to work from my mild cognitive impairment. So this is the basic book, Medical Marijuana 101, highly recommended, cheap, gives you a good idea about what people are talking about with cannabis. And then this is the book that I'm trying to get you to get because it's so good. And if you get it next spring, I'll get some royalties out of it. Not much. The other is if you're bored and you want to play something that's almost like a video game for stoners, go to leafly.com. It's so cool. You can look up purple Urkel, and there are thousands of descriptions by stoners who say, oh man, hey, I feel like, I don't know, but I really feel cool when I use purple Urkel. And it's just a trip, as it were, to read through all of these descriptions. But there's a lot of very serious data. And there are hundreds and hundreds and hundreds of strains that are summarized there. And I get hypnotized. I just keep going through the strains. And I can waste an hour just looking at all of these weird, the Pineapple Express and the purples and the Kushes and as you go through. And the White Widow, and there are just so many there. Okay, been a long day. Thanks for your attention.